So I'm Stephen Jan. I'm, as Chris said, I'm from the George Institute. I'm a co-director of health systems there and professor of health economics at the University of New South Wales. Before I start, I just also would like to acknowledge the traditional custodians of the land that we're on here today, the Gadigal people, the Eora Nation, the elders past, present and emerging, and if there are any Aboriginal people in the audience today. So before I start, I'd just like to acknowledge also the other presenters for the workshop and also the staff from Sphere who are here today. So firstly, from the George Institute, it's myself and Emily Atkins, who unfortunately come down with a cold, but she has prepared a lecture and I'll deliver it later this afternoon. From the Kirby Institute, University of New South Wales, we have David Bottinger. Can you put your hand up there? And Virginia Wiseman, who's not here yet, but she'll be here shortly. From the Centre for Health Economics Research and Evaluation, or SHARE, at the University of Technology, Sydney, Richard Debro-Lorenko, Joe Corello, and Rebecca Addo. And also from Sphere, we've got Merrily, who you met earlier. Liz Hennis, is Liz here? Yep, Liz. And I don't think Smita's here today yet, but she'll be here in the second day of the course. So, yeah, look, before I launch into the workshop objectives, and I'd maybe just go around the room and just get you to introduce yourself very quickly. So just your name and where you're from. And I think it's important that we do that because one of the things that we want to you to see this workshop as being is a networking opportunity. It's not just a networking opportunity between you guys, but potentially between you and us. Because one of the, I think, objectives of the course that I think Chris spelt out really well is that one of the things we want to achieve is greater impact through health economic evaluation through the work that you're doing at Sphere. So one of the things that we want to achieve over the next few years is a greater number of economic evaluation studies that are being done through the clinical, public health and health services research that you guys do. Having said that, I think Chris's target of 20%, I think, was a bit modest, actually. I think potentially any intervention study can have an economic component to it. If you're looking at impact, you're looking at effectiveness, then you're potentially also looking at cost effectiveness and value for money. And that's one of the messages that we want to sort of bring home today and basically show you how that might work in the design and running of an economic study. So before we do that, let's just quickly go through the room and just get you to introduce your name and your role and your organisation. So Wu, can we start there?
My name is Wu, Schlagdown Institute, head of project ops.
Thanks.
Talking stick helps, but it's not doing its talking stick job. Hello everybody, I'm Alicia. I'm also from Neuroscience Research Australia, research assistant in the Norms Balance and Injury.
It's a placebo microphone.
It's fixed. So Kim van Schoten, I'm from Neuroscience Research Australia as well, and I'm a researcher.
I'm Natalie Holsinger. I'm the Executive Director for Research Services at the Ingham Institute.
Hello, I'm Amy Freeman-Sanderson. I'm a speech pathologist based here at UTS and one day a week at RPA.
I'm Tobias Niven. I'm a project manager at Southwestern Sydney Local Health District.
Hi, my name is Jerry. I work at Western Sydney Uni School of Medicine in gastroenterology as a lecturer there.
Hi, I'm James John, Research Associate at School of Clinical Medicine, UNSW.
My name is Nan Hu. I'm from School of Clinical Medicine from UNSW, and I'm research fellow with background in statistics and epidemiology.
Hi, I'm Ben Hui from Kirby Institute. I'm a mathematical modeler.
Good morning, Gough Louis from Western Sydney University, a biomedical research fellow.
Good morning. My name is Rachel Coelho, and I'm a data analyst at NSW Health.
Hello, I'm Shireen Legaspi, and I'm a project officer with CESLED Southeastern Sydney.
Hi everyone, I'm Lachey Johnston, and I'm a change manager, also from Southeastern Sydney Local Health District.
Hi, I'm Laura Giblin. I'm also a change manager at CESLED Southeast Sydney.
Hi, I'm Danny Follett. I'm the strategic change manager from Southeastern Sydney.
Hi, I'm Carrie. I'm from Share at UTS, but I don't have any economic background.
Hi everyone, I'm Neil Anderson. I have an honorary position at Western Sydney University. I'm also from Medical Monitoring Solutions. We're commercialising a new system for easing the health and economic burden of cardiorespiratory diseases, hence my interest in this course.
Hi everyone, I'm Bronwyn Overs. I'm a research assistant at Neuroscience Research Australia, and I work in bipolar disorder research.
Hi everyone, Keith McNaughton again from Neuroscience Research Australia. I work in the Spinal Cord Injury Research Centre there, and we're running 4 intervention trials, so super interested in today. Thanks.
Hi everyone, my name is Ayako Tamaki. I'm from CESLED New South Wales Health, Research Business Manager. Thank you.
Hi everyone, my name is Bo. I'm from School of Public Health here at UTS. My role is biostatistician, and my job is doing biostatistics. Yeah.
Jane Ho, paediatrician and adolescent doctor at Sydney Children's Hospitals Network.
Good morning, my name is Ajay Varshni. It seems I'm the only consumer here. I'm from Sphere, sitting on 2 branches of theirs, AAA and MSK. I'm on the CAG of both of them.
I'm Gemma McAlane. I'm in a conjoint position with the University of Wollongong and St George Hospital. And my job is as an associate professor in nursing, so I work with the nurses to help them lead their own research.
Hi, I'm Nicola Strayton. I'm a nurse and a research fellow at the Nursing Research Institute at St Vincent's Hospital and Australian Catholic University.
Hi everyone, I'm Charmaine Strauss. I'm one of the project officers at Impact Trials Coordination Centre at UTS.
Hi, I'm Olivia Price. I'm doing my PhD at the National Drug and Alcohol Research Centre at UNSW.
Hi everyone, I'm Stephanie White. I have an academic role in the discipline of genetic counselling here at UTS, and I have a clinical role at Royal North Shore Hospital.
Hi everyone, I'm Hester. I'm currently medical advisor in the Population and Community Health Group in South East Sydney. I've done, most of my research has been qual. Numbers scare me.
Hi, my name's Kate Levitt. I'm at the University of Notre Dame in the School of Medicine in maternal health research.
My name's Mark. I'm an exercise physiologist, PhD candidate at Sydney University, and an ECI intern and colleague of Nick Strayton over at St Vincent's Hospital.
Hi, I'm Rachel Walker. I've got a role in speech pathology and research at Prince of Wales Hospital.
Hi, my name's Brianna. I'm also an exercise physiologist and a lecturer and researcher in the School of Health Sciences at UNSW.
Hi, I'm Talia. I'm a senior project officer at the Institute of Health Engineering at UNSW.
Hello, my name's Aidan Cashin. I'm a research fellow at Neuroscience Research Australia. My work is in clinical trials for pain conditions.
Oh, you're a presenter?
Oh, you might as well. Yeah, just introduce yourself anyway. Yeah.
Oh, no, yeah, all right. We'll start here.
Oh, sure, yeah. I'm Joe. I'm one of the presenters today. So I'm a research fellow at Share.
I'm Rebecca Addo. I'm also at Chair and one of the presenters here.
And to cap the trilogy from Chair, I'm Richard Diabru-Lorenzo, Associate Professor in Health Economics.
Yeah, hi, I'm David Bertiger, a Senior Research Fellow and Health Economist at the Kirby Institute.
Great, thank you. Thanks, everyone. Oh, one more person.
Sorry, I'm a bit late, a bit wet. Thank you. I'm Cherie Smith. I'm a Professor of Nursing at Western Sydney University. I do lung, sleep and heart health research.
Hi, Cherie. Good to see you again. Yeah, look, thanks. It's pretty clear that we've got a pretty diverse group of people in terms of background and experience. And it's also clear that we don't have any people who work as economists, which is fine. The idea of the course is to provide you with a basic grounding in economic concepts, and we assume no background knowledge in economics. Having said that, has anybody previously done any economic analyses or worked on a project? Yeah.
I actually did a graduate certificate in health economics, but
okay.
2020 at the beginning and then did 12 months in COVID response, so it's gone.
Oh, okay, you forgot that quickly. Yeah, no, that's great. That's great. What was the economic studies? Sorry?
Graduate certificate.
Oh, you did the certificate. Okay, yeah.
But seriously, I can't remember.
Sure. Well, hopefully something will trigger here. Yeah. Did you study or did you do work in?
I studied health economics and finance at UNSW part of my masters, but that was again. I feel like I've forgotten all of it.
Oh, okay. I'm sure things will come back, and some of the slides and the lectures have probably been recycled from the course that you've done. And
we use health economics, or we're starting to use health analysis as part of our trials.
as part of your trials, you've been using health economics. Which area? Falls. Yeah. Okay. Yeah, and I think that's the point of contact which we have with most clinical and public health researchers. But as I'll show in my first lecture later on, there are other types of work that we do other than economic evaluations and other opportunities to collaborate. But the main thing is economic evaluation, and that's the obvious sort of niche that health economists have, and then that's the entry point often to a collaboration. So the workshop objectives, 3 key objectives. Firstly is to provide a basic grounding in economics and economic evaluation concepts. And I think the first part there, the economics is important because it sort of gives you an insight into the way economists think. It's a perspective on the world. It's not just a set of tools, but it's also a framework for evaluating and looking at phenomena, basically. And we'll do that in the first lecture. Second is to enable individuals to critically appraise economic evaluation evidence and understand its strengths and limitations. So all economic studies come with assumptions. People always joke about the assumptions economists make in their studies. And it's true that often you do need to make assumptions. We often do modelling. We often deal with imperfect data. And so in order to come up with findings around cost effectiveness, cost benefit, or whatever, you have to make assumptions about. And the key is a good quality economic evaluation is that you make explicit those assumptions and you test those assumptions. And we'll talk about the methods involved in doing that. And thirdly, to provide guidance for non-economists, particularly individuals working in public health, health policy, and clinical settings, to engage with health economists and establish the investment case for new programs and policies based on economic evidence. Okay. So I think that's important. Ultimately, the end game is to the investment case. An economic evaluation, doesn't have that much intrinsic value unless it informs a decision. So often we have to be a bit pragmatic in how we frame our economic analysis, and it's got to be linked to a decision that's happening down the road. So we'll talk a bit about that and how we interpret evidence and how we might then use it as a decision maker to inform the way in which we make investment decisions. And finally, I've put a fourth there. Anything else? Has anybody got anything else that they want to take away from the next 2 days of this course? You can think about it anyway during the course of this day, but we are going to try to be as interactive as possible. We're going to have lectures where we would like you to ask questions, and so if things come up during the day and you want to see them resolved in the discussion, let us know. Okay, so here's an outline of what we've got planned. You would have seen this, you would have been sent the program, but so we've got the introduction session this morning, which I'll give. So I'll give you an introduction to some of the key concepts in economics and economic evaluation. And then after morning tea, we'll have 2 sessions about how to do economic evaluation. So we won't go into too much depth, but it's important to know how to do it, even if you're not going to do it yourself. It's important to know what role the health economists will play in carrying out the economic evaluation study, what sort of data they need to collect, how we plan for these economic analyses, and some of the assumptions and techniques that are involved in doing the economic evaluation. So Rebecca will go first, and she'll talk about some of the practical issues in economic evaluation, issues around costing, data collection and discounting. And second lecture will be by Joe, who'll talk about some of the practical issues in economic evaluation on the benefit side. So Rebecca's looking at the cost side, Joe's looking more at the outcomes or benefit side. So we're looking at different ways in which we evaluate outcomes in an economic evaluation. So looking at quality of life assessment, willingness to pay, values of statistical life, inclusion of productivity losses. So after lunch, we'll do some practical work. So that'll be led by David and Verge from the Kirby Institute. So they'll present a case study of an economic evaluation, and then you'll go through an exercise where you critically appraise it. And we'll have an opportunity within that session to do some feedback and group discussion. And then finally, in the afternoon, we'll talk about how you build in an economic evaluation alongside an intervention trial and other forms of intervention studies. And so it's not just trials. When we say trials, we're not talking about randomised controlled trials. We're also talking about pragmatic impact evaluations. They're also amenable to economic evaluation. So a lot of the work that I do at the George Institute, because we specialise in large-scale randomised trials, is done alongside RCTs, but it's not always the case that you have to just that's the only type of impact evaluation studies. And we'll talk about how you build in economic evaluations alongside these studies. And then finally we'll have a bit of a Q&A. So Richard and I will sort of chair a Q&A session where you can just throw questions at us based on the... or at Richard at least. So we'll aim to sort of finish up by 4:45 today. Okay. Any questions about the structure of the day? No. Anything you want to add?
Steve, can I just say, sorry,
Yes,
I just wanted to point out to everyone that we are recording today, and so when you ask a question going forward, if you could make sure you speak into the mic so it can be picked up on the recording. Thank you.
Great, thanks. And next week we're back here on the 30th of November, Thursday. So it's a half-day session, and it's a very practically focused. So I asked you all to sort of submit some case studies based on your work, and we picked 3, and we aimed to sort of get a good mix of one policy, one health services, and one clinical example. And we've got 3 speakers lined up. I can't remember off the top of my head who they were, but maybe during the course of the day we'll get together and just have a quick chat and talk about this session. The session will be, well, firstly, after the recap, we'll get a presentation of 3 case studies. So the individuals who've been picked will present their case studies, and then we'll have a group exercise where we will go through a checklist on the planning and design of economic evaluations and get the groups to design an economic evaluation around each of these case studies. And then we'll get feedback and presentation and discussion around it. Okay. So hopefully that'll give you a sort of a practical feel for how you get something off the ground and some of the issues around data, even things like I guess quality control, budgeting, those sorts of things we can talk about as well, because they're sorts of nuts and bolts sort of issues that you do have to deal with if you're collaborating with a health economist. Okay, great. No questions, comments? No? Okay, so I'll start on the first lecture. So this is, as I said earlier, it's an introduction to some of the key concepts in economics and economic evaluation. I think in a lot of the sort of health economics courses that you do, we often just jump straight into the health economics and you know, go straight into the techniques that are involved in the economic evaluations. But we felt that for this course, at least, we would just do a bit of a discussion around broader economic concepts and the way in which we approach problems from an economics perspective. So these are the objectives of this session. So firstly, understand basic economic concepts, including demand, supply, and the role of markets in an economy. You often hear a lot of this discussion when you turn on the news. Sometimes it can be a bit sort of jargonistic in how they present it, but it sort of boils down to some fairly basic sort of concepts and also value judgments. And I think it's important to understand that economics is founded on certain principles, and often those principles are underpinned by certain value judgments, and it is useful to understand that. And a lot of that revolves around the role of markets in an economy and ultimately in a society. But we also need to understand that markets don't often work optimally, particularly in the healthcare setting. And I'll talk about the idea of market failure and the reasons why markets often fail in a healthcare setting. And then thirdly, we'll try to understand the role of economic evaluation in informing resource allocation decisions in lieu of markets. So this is important. Economists often think of markets as the first best solution. That's the term we often use. First best, second best. And then if markets aren't going to operate efficiently or equitably, or if there's some form of market failure, then we turn to alternatives. And this is the way in which we frame the economic analysis. So in an ideal situation, we'd have markets in the healthcare setting, and they'll allocate resources and distribute to people who are willing to pay for it. We then identify problems with that model, and so what do we do as a second best solution? So the second best solution often involves government intervention. But how does government decide to allocate resources? It's got to have some sort of framework for evaluating whether money goes here as opposed to here, and that's where economic evaluation comes in. So that's a potential framework that governments use. It's not always what they use. I mean, politics often comes into it. Consumer, peer interest group, clinician pressure can often influence the way in which funding decisions are made. But economics also provides us with a framework. And hopefully, you know, it incorporates some of these other sort of factors as well in the way in which we make decisions. So the third objective is to understand the role of economic evaluation in informing resource allocation decisions in lieu of markets. And then, in addition to that, I'm going to give you 2 case studies of how we use economic evaluation in health policy currently. So economic evaluation is already being used, and I'll give you 2 live applications of economic evaluations. The first one is a very small scale application of economic evaluation that's currently in vogue in New South Wales, in Australia, and in a global health context as well, is this idea of social impact bonds. Is anybody familiar with that idea, social impact bonds? No, well, I'll give you, well, I'll talk a bit more in detail about it in a sec. The other area is health technology assessment, and that's an idea which has been around for a few decades. It's really taken off in Australia. Australia's seen as a world leader. The obvious policy example is the Pharmaceutical Benefits Advisory Committee, the PBAC, that decides on the listing of new drugs in a healthcare setting. And that's an example of where economic evaluation has been embedded into a policy framework. And I'll talk about how that works. So it gives you an example of economic evaluation isn't something that we do as researchers. It's also something that policymakers are increasingly embracing in their decision making. Okay. So that's the outline of the lecture. So here's a definition of economics. It's a bit outdated, as you can see, but it does come from Paul Samuelson, who's a bit of an authority in economics. His textbook is probably the most widely cited textbook. I think it was written originally in 1940s, but it's still often used in economic courses around the world. And this is, I guess, a sort of classical definition of economics. It's the study of how men, and I guess women, and society end up choosing with and without the use of money to employ scarce productive resources that could have alternative uses to produce various commodities and distribute them for consumption now or in the future among various people and groups in society. It analyses the costs and benefits of improving patterns of resource allocation. So you can see in this definition, there are three things that I've highlighted important. Firstly is scarce resources. So where economists deal with this concept of scarcity. It's about making decisions in the face of scarcity. So if there's no scarcity, then there's no economics. You don't need economic framework to make decisions because you just do everything. But so what we start off with is this assumption of scarcity. There are infinite number of things that could potentially do good, that would have value, but we can't do everything. So we've got to make choices. And economics gives us a framework for making those choices. And the framework involves looking at the costs and the benefits associated with options. And that helps us decide which courses of action are best and ultimately what allocation of resources we need to decide on. And that'll come into play very clearly when we're talking about the economic evaluation tools that we have at our disposal. So, I mean, the economic problem, therefore, is about how much of what sorts of resources we allocate to what forms of healthcare, how and for whom. And then also how these questions are addressed in the economy at large. So this gets back to the point, we've got, as an economy, as a society, we have resources. How do we, as a society, decide on how these resources are allocated? By and large, in Australia, we live in I suppose, a capitalist economy, a mixed capitalist economy. We have a large government sector, but largely determine the resources through markets. So in large part, the resources that are allocated through, in our society, are allocated through markets. So the question rises, why don't we allow the market to decide? So for most goods and services, under ideal conditions, markets allocate resources efficiently. So that's important to understand, under ideal conditions. Sometimes close to ideal conditions is good enough, but under ideal conditions where we have and I'll talk about what those conditions are in a sec, but under ideal conditions, markets, in theory, allocate resources most efficiently. And markets involve the interaction of consumers on one side, so demand, and producers through price mechanisms that ensures that the right quantity of the right types of goods and services are produced. So that's production on the supply side. And also the market ensures that only those goods who are allocated to those people who really value them takes place. So that happens on the demand side. So there's demand on one side and supply on the other side, and markets enable us to allocate resources from suppliers to buyers in the most efficient way through a price mechanism. So as you can think, it's in a way, if you're the person who values something most, then you have a willingness to pay that's higher than somebody who only values it not as much as you. So in theory, you're more able to access that good or service through a market than the other person, because that person might be only willing to pay, say, $5 for a product, and you might be willing to pay $10. So through a marketplace, your strength of preference is realised through a purchase decision. You're more able to purchase that good based on your greater willingness to pay and your strength of preference. And that's, in a sense, a mechanism that determines efficiently, under ideal conditions, the allocation of resources through a market. So what do markets do? So there are a number of good things, positive features of markets. You may think of some negatives, and I might press you on that, but there are some very clear positives. Well, firstly, they bring buyers and sellers together. Secondly, markets involve voluntary exchange. So if I'm selling something to you, for instance, through eBay, I might have a pair of shoes that I want to sell, and you go onto eBay and you want to purchase those shoes. I set a price of $100. Nobody's forcing you to purchase it. Nobody's forcing me to sell it. We involve voluntary exchange. So ultimately, because it's voluntary and that transaction takes place, we're both better off at the end of the transaction than we were before, because we've achieved our objective. So through that transaction, we have this situation that from prior to the interaction to after the interaction, we have two people who are better off as a result of that interaction. Does that make sense? And that idea is known as Pareto efficiency, or Pareto efficient exchange. And that's a concept that underlies a lot of economic thinking. It's about gains from trade, mutual benefit, and this idea that two consenting adults go into a transaction and walk away better off. And the aggregation of those consensual interactions or transactions is the way in which an economy moves from one position to a better position through market exchange. It's a rationale, for instance, why economies like China open up to a marketplace and kick off a process of economic growth through mutual trade and mutual exchange. Does that make sense to people? It's a thinking. This is the best way in which we can improve the well-being of the individuals within the economy by allowing them to engage in mutual beneficial exchange. So another aspect of markets is that it transmits information. So through a price mechanism, we also transmit information about the quality of a product. So if for instance, if you're going on eBay and you see a pair of shoes that are $50 and you see another pair of shoes for $200, that sort of transmits information to you about the quality of the product, doesn't it? So markets are, in a way, a process in which we can also transmit information. And fourthly, it ultimately allocates resources. It determines how resources are allocated. And through that aggregation of Pareto efficient exchange, the idea is it does so efficiently by creating an equilibrium between demand and supply. So we have markets, but we also have competitive markets. And markets are competitive when there are a lot of buyers and a lot of sellers. And people are pushing each other to, buyers are pushing each other in terms of bidding up a price, and sellers are pushing each other in terms of bidding down price in which they're selling, but also increasing quality. And that drives efficiency in markets. So competition in markets does three things. It keeps prices low, it enables choice, and it encourages innovation. Okay. Does that make sense? That's in theory. I don't want to seem like I'm a free marketeer, but I'm just giving you at least the theoretical construct that underlies a lot of this. And we'll talk about failure and all of that. But okay, so competitive markets. But competition in markets, there are a number of conditions that need to be met for markets to be competitive. So firstly, there needs to be perfect information or near perfect information. There has to be good information. If buyers or sellers aren't very well informed, if they enter into a marketplace with poor information, then you can't have a competitive market. If I go into eBay and I know nothing about, if people know nothing about the product that's being sold on eBay, then you would argue that that's not really a competitive market. There've got to be many buyers and sellers, so there's got to be a critical mass of buyers and sellers in order to drive that sort of price pressure and quality pressure. It's got to be free from externalities, or at least relatively free. And this idea of externalities, does anybody know what this term externalities mean? No? Okay, so think about what I talked about when I said Pareto exchange. So two consenting individuals engaging in exchange in a marketplace. I buy your product, we both go away and do well. The problem is that often when we engage in exchange, there's a third party that might be affected by the transaction who doesn't have a say in the interaction. So for instance, if we're selling arms, for instance, or we're selling a polluting product, or we're selling something that, say we're selling antibiotics and creating a third party externality resulting from antibiotic resistance. So there are the side effects from these transactions, and they impact on other people. And if there are significant externalities associated with a transaction, then you can argue that there's a reason for a market failure in areas. And you're probably already thinking, a lot of these are applying in healthcare. You're thinking a lot of these assumptions don't necessarily follow very well in a healthcare context. And fourthly, the other assumption, the key assumption, is that there are no barriers to entry. So buyers and sellers are free to enter and exit from the market. If you're forced into a market, or if there's a blockage into a market, then you can't have a competitive marketplace. Okay. So the question there is, do these apply to healthcare? Can I have a show of hands? Do you think they apply to healthcare? Yes? Yes? A few?
Do they exist or do they work?
Do they hold? Do these assumptions hold in healthcare? Do we have competitive markets in healthcare? Can I see a show of hands? I can see a lot of shaking, but a few like that. And no. So I guess pretty much most people. Look, I would sit on the fence a little bit. I would say for a large part, no. For a lot of healthcare products, we can't really have competitive markets. But some areas of healthcare, we may be able to. We may be able to. And we do. We have, drugs are to a large extent are produced in a private marketplace. There are, I'm sure you can think of other areas of healthcare that are produced in private sector, and potentially more efficiently in the private sector than they are in a public sector context. But what I'll do now is just focus on market failure and the reasons why these assumptions often break down in a healthcare setting. Not just healthcare, health setting. So I'm thinking of public health as well, probably more so in public health than a healthcare setting. So firstly, perfect information. So buyers and sellers are perfectly informed about the product that they receive and therefore are able to engage in mutually beneficial exchange. Does that apply in healthcare? No. Sorry, I can see you shaking. I'm just trying to make this interactive. Can I ask reason?
I was just shaking my head because you're assuming informed consent, or those sorts of things that you can't possibly know because you haven't got the same background or education or information that you're coming to or biases that you come into the party with.
Yep, absolutely. That's right. I mean, one of the key sort of principles between, for instance, a doctor-patient relationship is that you're not going into the doctor's clinic as necessarily a perfectly informed consumer. You go to the clinic because you need information about what your condition is and what services and medications you might need. So in that sense, there's not that sort of separation of demand and supply, where the consumer is perfectly well informed, knows their rights, goes into a transaction and engages in exchange. You're actually going to the seller, you're going to the doctor, and you're asking the seller, what do I need, and what have I got wrong with me, and what products. So what we have there is what's known as an agency relationship. It's a relationship that's based on this idea that we have an agent who operates on behalf of the consumer, and that sort of helps us in the healthcare setting address this idea of information asymmetry. That's another piece of jargon that we often throw up, information asymmetry. So the asymmetry in information between buyer and seller. And the problem, of course, is that when you're in that dependent relationship, when you're dependent on the seller giving you the information, it involves often, it leads to a situation where there's potential abuse, I guess. You may have encountered that in markets. Sometimes if you've ever had to get your car serviced or get something repaired, you go to the smash repairers and you say, "Oh, can you tell me what's wrong with it? Or what do it need done?" And invariably they'll always say, "Oh, well, it's a big job," and you're at their mercy in a sense. You're relying on them to provide you with information as well as the service at the end of the day. I guess you can probably shop around and get and come up with a much more competitive outcome. In a healthcare setting, it's much more difficult, and therefore what we would argue is that we don't have the condition there for a perfectly competitive market. Many buyers and sellers, is that the case? Sometimes. Can you elaborate?
Probably depends. Yeah, I guess it depends on the service, right? If you're a specialised area of, I don't know, neurosurgery or something, but if you're, I don't know, physio or a EP, there's probably lots of options, but that really specialist area, not really.
Yeah, no, absolutely. I think it often depends on the condition, the specialty, but also geography. Whether there are many buyers and sellers. There's certainly many buyers in terms of sellers, and in a way, what we do, we've institutionalised scarcity in terms of the sellers. We have registration processes. We have a limit on the number of doctors that are available, and often these are for good reasons. And so it is possible. Well, you could argue that it may not be desirable to have thousands of medical practitioners, running out there and freedom of entry and exit into the market. We do want to create some walls, some barriers to entry into that marketplace. So yes, so that again is an assumption that you could question in the healthcare setting. Externalities. So I've put a couple there. First one is equity. I think one of the things we often lose sight of is this idea of equity, particularly when we're looking at economics. We always think, well, it's focused on efficiency, cost effectiveness. that sort of thing. But equity is a huge consideration for policymakers, and therefore it should be a consideration for us when we're doing an economic analysis. And equity matters in healthcare, perhaps more so than it does in many other sectors of the economy. So I, for instance, care about the sort of healthcare that you have access to. As a community, we feel, you know, affronted if somebody isn't able to access healthcare when they need it. We don't feel the same affront if somebody has less access to a car or to, you know, a holiday once a year. So those sorts of things, there's that less of a social sort of concept. And the term that economists sometimes use is a caring externality, equity sort of concept, which applies to healthcare that perhaps doesn't apply to many other sectors of the economy. And that's why we often need to moderate our sort of use of markets in the healthcare setting. The other area of obvious externality is that, you know, often, you know, particularly with infectious diseases, it's not about a one-to-one transaction. If somebody doesn't get vaccinated, doesn't engage in that transaction, it affects the rest of us. And we saw that obviously during COVID, that there's huge externality impact associated with the consumption of healthcare. And so in those examples, we don't necessarily leave vaccination to the marketplace. You can imagine if it was purely a market-based situation where we had a vaccination program. You only get vaccination if you're willing and able to pay for vaccination services. It would sort of defeat the purpose of having the program to begin with, wouldn't it? And finally, no barriers to entry. Well, there are often very significant barriers to entry, and often for good reason in the healthcare setting that you don't get in many other sort of markets. And the obvious ones are professional barriers to entering into a marketplace. Okay. Any questions so far? Okay, so the implications of market failure. So we had the reasons why markets often fail in healthcare and why it's not often that first best solution that we turn to. It's that second best solution that, therefore, we want to sort of invoke when we're talking about how we allocate resources in the healthcare setting. And some of the implications of market failure. So in relation, and we talked about this a second ago, in relation to the information asymmetry, we ensure that we take advantage of that agency relationship. We institutionalise this process where consumers rely on doctors or healthcare professionals to provide them with the information that they need to engage in the exchange. And to regulate that relationship, to ensure that there's no abuse, we have professional standards or professional ethics to ensure that, that the decision that ultimately comes out of that interaction is the decision that the consumer would have made if they were fully informed. So that's the ideal situation, is that the consumer still has a choice. We're still sort of, but what we have is, through this relationship, is ensuring that that choice is an informed choice. So other implications of market failure is we have three areas of government intervention. So we have governments who will just come in and provide services. So we have public hospitals, public clinics, public health programs. Governments will just come in and provide the service rather than leaving it into the marketplace. The second area of government intervention is government may not necessarily provide the service, but might finance the service. So might pay for the service. And the obvious area is Medicare. So if you go to a GP, the GP themselves isn't a government employee. They're paid by government through Medicare reimbursement, but the GP themselves is a self-employed professional. So there you're talking about government finance rather than necessarily government provision. And the third area of government intervention is government regulation. So we can regulate a whole range of areas. So we can regulate in terms of price, ensure that prices are set at certain levels. We can regulate in terms of quantity, quality, or information. We can ensure that information is provided through regulation. And then fourth, we can have government intervention in terms of trying to achieve greater equity in services. So ensure, because markets, as you probably sort of been thinking, won't necessarily produce, they may produce efficient outcomes, but won't necessarily produce equitable outcomes. So one of the things that we want to see in a healthcare setting is healthcare that's provided, equitably across the population. So in rural areas, remote areas, we ensure that people have reasonable access to healthcare. A market won't necessarily enable that. We need something else to maybe push that along. And also across different populations, to Aboriginal and Torres Strait Islander populations, to migrant populations, whatever. We may need an additional policy push to ensure equity. So that's a long-winded way of getting us to economic evaluation and where we're sort of the starting point for this course. So in lieu of competitive markets, and we have government intervention that's required on a number of levels. You saw all the different levels that government intervention is required. So without markets, how does government determine the allocation of resources? So how does it sort of say, well, I need to invest in drug A or drug B, or treatment A versus treatment B, or in population. So treatment or prevention, this is an example. So treatment or prevention, cancer versus cardiovascular disease, injury, program A versus program B, drug A versus drug B. We don't have a market to do it. We need somebody to make that decision. It's a big decision. I mean, you can see now that the markets actually do a lot in a society because this happens very invisibly in a competitive marketplace. Now what we need to do is, in a sense, Soviet Union sort of style, we need an administrator to make these sorts of decisions. And how do we ensure that that administrator makes those decisions in the best interests of the community, both efficiently and equitably? And you can see in the Soviet Union, we had a lot of problems ensuring that that was going to be the case. So economic evaluation is a tool that enables us to move towards that ideal. So here's a definition of economic evaluation. It's the comparative analysis of alternative courses of action in terms of both their resource costs and their consequences. So we're looking at costs and outcomes, and it's a framework for looking at both when we're making decision making. So here's a very simplified presentation of the way in which you do an economic evaluation, how they're sort of set out. So you have two alternatives, program A and program B. And as an economist, I need to look at both and compare the costs, and so what goes into these programs and what comes out of these in terms of consequences or outcomes. And the important thing is, so we value the differences in costs and consequences between A and B. So I look at A and B. So say A is, often when we're doing this, one of these options is the status quo option, the usual care, the do nothing. The second is the new treatment or the new option. So what we're doing generally in economic evaluation is saying we're at the state of the world now, let's evaluate the costs and benefits of moving to state of the world that we would be once we implement this new intervention, this new drug or this new medical treatment. And in doing so, what we say is, what are the additional costs to the community or to the health sector associated with moving from A to B? And what are the additional benefits that we gain? And what we're doing there is ultimately looking at the incremental costs and benefits of moving from state of the world A to state of the world B. And that's the principle that underlies all the economic evaluations that we do. It's an incremental analysis. It's this idea of moving from the status quo to a new position, and what are the additional costs and what are the additional benefits. And the idea, if you take a sort of high-level view, is that if we keep doing that, all the time, we're ultimately moving society ahead. We're ultimately moving to a position where we're ultimately moving to a better place based on these incremental changes. So one would be the new program, one would be status quo or standard practice. So I'm not going to go into details about what these economic evaluation techniques are. They differ slightly. They have the same principle, underlying principle, which I just gave you in the previous slide. But Joe's going to talk in a bit more detail about what these economic evaluation techniques involve. But there are 5, generally speaking, techniques that we can use to evaluate the costs and the consequences of economic of intervention. So, cost minimisation analysis, cost effectiveness analysis, which is the one that you've probably most come into contact with, cost utility analysis, cost consequence, and cost benefit analysis. Okay. What I will do is just give you just a taste of how these findings from a cost effectiveness analysis are presented, just to give you an idea of that incremental cost effectiveness which underlies this approach. So we have 2 treatments. Treatment A would be the new treatment. So it costs $800, increases life expectancy by 1 year. Treatment B is $500, increases life expectancy by half a year. The reason why I would say treatment B is more likely to be the status quo is that often, I'd say 90% of the time when I'm doing economic evaluation, is that we're faced with a situation where we have a status quo and we have a new treatment that claims to be more effective but will cost a bit more. And what we're trying to work out is the value for money, okay, of the approach. It's not always the case that happens. Sometimes the new treatment might be cheaper, or sometimes new treatment might be less effective. And in those situations we have, it's almost, you don't even need to do an economic evaluation, but most economic evaluations involve a situation where there's a claim of greater effectiveness but also additional cost, and we're trying to balance the two. And this is one way you might sort of graph that. So you can see treatment B, $500, half a year life saved. Treatment A, $800, 1 year of life saved. So you can see you're moving from B to A with this new intervention. The way in which we often present this cost effectiveness problem, or the solution, the finding, is in this is what's known as an incremental cost effectiveness plane. What we have here is a plane where we have on the horizontal axis treatment effectiveness, and on the vertical axis cost. And as you can see, it's $300 more expensive and half a year of life more effective. So we have an intervention on that red dot, which is known as the northeast quadrant, where, as I said, 90% of economic evaluations take place. We have but we potentially have economic evaluations that occur in these other quadrants as well. So a situation where the new treatment is 0.5 of a year more effective and less costly than the intervention. What would you do? Yeah, it's a no-brainer, isn't it? The new treatment dominates. It's cheaper and it's more effective. Why wouldn't you just do it? Conversely, you have an intervention in the northwest quadrant, which the new treatment is less effective and more expensive. And again, you've got no-brainer. Why would you do it? Because it's going to cost more and it's going to save less lives. The southwest quadrant is an interesting example where you have a new treatment that's less costly, so it's cheaper, but it's also less effective. Now, in an Australian setting, you're unlikely to ever sort of get this off the ground. Politically, it's very hard to get government to sort of invest in something that's going to be less effective, even if it saves a lot of money. In low-income settings, low-income country settings, some of you may, or I mean, we do a lot of our work in in low middle income countries, this might be a live option, particularly if you're saving a lot of resources. Because another concept that comes into play is opportunity cost. If you can save a lot of resources and reallocate that money to something that potentially more life-saving, then you're ultimately achieving a benefit to the health sector. So, as I said here, politically that's probably, in Australia, probably a non-starter, but it is something that sometimes comes up, a new treatment that's less costly but also less effective, and that can potentially be subject to an economic evaluation. But as I said, about 90% of our problems happen on the northeast quadrant. So the way you present this particular example is you have an incremental cost effectiveness ratio. You have $800 minus $500, 1 year minus half a year, come up with $600 per life year gained. Does that make sense? Pretty simple maths here. It's not always this simple, but the calculation is basically this, pretty much what we do when we're doing an economic evaluation. So, if you're a decision maker, would you fund this program? $600 per life year gained. Some shrugs. Look, I guess the obvious question, well, what's the benchmark? What we do? But generally speaking, we probably would. In the Australian context, that would be considered extremely good value for money. You know, if you're buying a life year gain at $600, that would be considered very good value for money. And the reason why I know that is that we do have some thresholds that we can sort of benchmark that against. So it's this idea of what's the government willing to pay for a life year. So we have a threshold, usually framed in terms of a quality adjusted life year. Again, I won't give you much detail about what that is yet. Joe will talk about what a quality adjusted life year. It's essentially the same principle as a life year, but it's adjusted for quality of life. And in the UK, they have an explicit threshold of £30,000 per life year gain. So anything below that is considered cost effective. So $600, yes, much lower. Australia, we don't have an explicit threshold. We have an implicit threshold based on people looking at past decisions made by the PBAC, and it happens to be around $50,000 to $70,000 per quality adjusted life year gain. So anything below that is considered cost effective. Anything above that is generally considered not cost effective. There are exceptions, but generally they fall within it. WHO has sort of tentatively put out a threshold of 3 times per gross national income, but they've sort of stepped back a bit from that, and they've come up with more recent estimates, more around 1 time gross national income. But there's nothing official, and certainly they've been these are thresholds that have been fairly arbitrarily set. But once they've arbitrarily set and people start using them, they take a life of their own. Because if all these decisions have been made in the past based on this threshold, it's very difficult then to not use that threshold for the current decision. So even if there was no theoretical or empirical basis for the original threshold, once they start getting used, they take on this life. So in short, economic theory, so this is just a summary of what I've just presented so far. Economic theory, markets are seen as Pareto efficient means of allocating resources in society. Markets are often seen to fail in healthcare for those assumptions. We had 4 assumptions, remember? Information, actually I'm testing myself now, I'm not sure if I remember. Information, many buyers and sellers, barriers to entry, and what's it? Externalities, yes. Yeah. You can also throw equity in there. Equity is not often seen as a market failure per se, because markets really sort of, people acknowledge markets aren't meant to be equitable, so it's not a failure per se, but I guess it's a social policy failure if we haven't achieved equity through markets. Government intervention can be required to address these market failures, and economic evaluation is a tool to guide resource allocation in lieu of competitive markets. Okay, so we've got still 20 minutes, and I'm going to go through 2 case study examples of economic evaluation that's been used in policy context. Before that, I just want to see, does anybody have any questions on, I suppose, this theoretical side? Sorry, I had to get the theory out of the way before we move on to practice. Yes?
Two questions. One, can a medical field... Can a medical field guarantee, when you said $600 for 1 year, that I will get 1 year?
Look, don't blame the economists if you don't get that year. Blame the clinicians. But ultimately, it's based on the evidence. So obviously...
I understand, but I'm just taking that.
Yeah.
The second one you said, which is not possible to be compared a mechanic as against a neurosurgeon or a cardiothoracic surgeon. To get a mechanic, I can get in 2 days at least 10 different codes. But I cannot find too many cardiothoracic surgeons or brain surgeons.
Yeah, that's exactly
and
the
whatever
point.
they say, I have to accept because it is just what it is.
Yep.
If they say it's going to be this much,
Yep.
that's what it is going to be. And none of, it is just not possible.
Yep.
So comparing those two is just not feasible.
That's exactly the point. And that's why we have markets. We have markets for smash repairers, but we don't have markets. Well, we have high degree of government regulation in relation to cardiothoracic surgery and specialist care, and that's the reason why the information and also choice, ability to choose across different means that we can't leave it to pure markets to determine how we access a cardiothoracic surgeon. Yep.
Thanks for that great introduction. Can you just clarify the difference between the implicit and explicit markets, or that sort of idea between the UK and Australia? Does that mean the UK have a line saying if it's above 30k, no chance, and there's a bit more negotiation or leeway in Australia? Is that, am I right in that understanding, or not quite?
Yeah, that's right. The UK, they've published that threshold. Australia, they haven't published it. I actually was I was a member of the PBAC Economic Subcommittee a few years, and during that period we were doing one of the revisions of the guidelines, and there was talk about trying to make explicit the cost effectiveness threshold in Australia, but there was a strong resistance, and rightly so, because we have a different system in Australia. In the UK, the submissions that come in for new drugs and they're done by academic and third-party sort of groups that put it. In Australia, we have an adversarial system where the submissions come in from industry for new drugs. And the thinking is that if you give industry a target, they're going to hit it. And then if you have an explicit threshold, then your hands are tied in terms of how you make that decision. So there's a feeling that, we do have an implicit threshold, but we don't want to sort of commit ourselves to saying if it's fallen below, we have to fund this.
Is there a danger that a lot of those costs in the UK are coming at just £5 under 30 grand, or do you see that?
Yeah. And in Australia as well. I mean, if you have a new drug and you come in at $10,000 per quality adjusted life year, it means your pricing manager is going to get the sack the next day because you haven't priced the drug. You've left money on the table essentially, and that's the criticism of this approach, is that it sort of for really low cost things, potentially low costs, you're encouraging people to sort of move up.
Steve, can I
Oh yes, Richard. Yeah.
On that point, there has actually been an analysis looking at pricing outcomes in the UK versus Australia for the same drugs, and it's precisely as you just suggested. Prices in the UK are higher because they price just below that threshold, whereas we don't.
Okay. Yes, Mira.
I had one question, and it's more in regards to a public health perspective. So, the figure that you gave, is it for like an individual person, like for the one life year gain, or is there a different way we look at things if it's for public health? For example, COVID vaccines.
It's on average per person. So yeah, it's an average. So obviously there can be a lot of variation across people, but we try to keep the same metric for public health. It doesn't always work because public health achieves outcomes that may be different from clinical interventions. But ultimately, if we're going to use this approach universally to allocate resources, we try to come up with universal measures that enable us to make decisions between public health, clinical policy. So the cost per quality sort of framework, and Joe's going to talk about later, helps us get there because a quality adjusted life year is seen as a universal measure. It's something that we want to achieve in public health, but we also want to achieve in clinical medicine. It's about quality adjusted life year survival. Yeah.
Thank you. This is fantastic. Really really helping me to understand it. I'm interested, and it may not be anything to do with it, but the inverse care law. So the people that need most care are less likely to get it.
Yeah.
That's just a market failure?
Yeah. Look, it's an equity failure. It's a market failure because, yeah, absolutely. It's very clear that. Even in highly regulated healthcare systems, we still have that failure. That we have doctors who want to live in Sydney. Not many doctors want to live out, a remote community because they're just like us. They like the sort of lifestyle that we have. So we often have to have measures that incentivise people to go out to these places. Not just incentivise, maybe in a sense coerce in terms of regulations, things like, But anyway, that's an example of a. You can call it market failure or you can call it a policy failure, but it is something that, it's certainly something that a market won't address on its own. But in many other goods and services, that won't happen because if people want something, if they want a product, they want a new car, they want a new new iPhone, the fact that there's higher demand for that product will drive the price up in those places, and therefore the market takes care of that problem by ensuring that those resources are allocated based on that market demand. Okay, look, I'll move on to these examples. They're quite quick. This is the first one is as I mentioned earlier, social impact bonds, and this is a method of financing health and social programs. It's been around not very long, since 2010, was first launched in the UK. The global market, I got this figure a few years ago, so it may have increased quite a bit now, but even still, it's peanuts at the moment. 200 million in those days. It's mainly been used not just in healthcare, but primarily, in fact, social programs, including social justice, homelessness, and health. And involves programs that are delivered by non-government organisations, essentially delivering services that may have traditionally been provided by government, but now have sort of been contracted out to non-government organisations, often charities, things like juvenile justice, sort of rehabilitation, those sorts of things, and certain healthcare programs as well. And the idea is that these programs are if they're cost savings to government, if they're keeping people out of prisons, if they're keeping people out of hospital, then we can capture that benefit and use that as a means of encouraging private investment. That's a benefit, and I'll talk about how we do that in terms of. But that's the entry point for these social impact bonds, and it's a way in which we encourage private investment into these programs in order to, relieve the pressure on governments to invest in these programs. So, the way they work is. These programs are set up. So, for instance, it's a program for mental health. It's the aim of the program is to keep people in care and reduce hospitalisations through, and it's being delivered by a charity. And in order to get the program set up, we established these bonds, these social impact bonds. They're like shares in these programs. And these bonds are underwritten by government. So they're underwritten in New South Wales, have been underwritten by New South Wales Treasury. And we issue these bonds and people come in and they invest in these shares or these bonds. And what these social impact bonds enable is governments to access private capital. So it brings in new money into the health system. It also offsets the risk to government of investing in these programs themselves. If government was investing in these programs, then they're bearing the risk. If these programs are duds, then they bear the loss. So in a sense, they're saying, well, private markets are better equipped to handle risk. Let's outsource that risk to private markets. And it also incentivises providers through this payment for success model that happens in social impact bonds. So in Australia, it's had strong support amongst investors. There's a big movement to impact. An organisation called Impact Investing Australia has sort of been behind a lot of the sort of push for social impact investment. But it's usually run by state treasuries. And I'll give you an example of how it's run through this case study. This is the first cab off the rank in New South Wales. New South Wales government was the earliest adopter, and their first program was called the New Pin Pilot. And it was a Uniting Care parenting program to support families to avoid children being put into out-of-home care. So it's keeping kids out of juvenile prison. And I won't go into details of what the program involved, but the upshot was there was a social impact bond issued for this program. And after 3 years, what they found was it restored 130 children to their families, prevented 47 children entering out-of-home care. So there was a restoration rate of 61% over 3 years versus a baseline of 21%. So it was highly effective. And based on that level of effectiveness and based on a pre-specified payment schedule, so government, when it issued this bond, said if it achieves this restoration rate, we're going to pay out to investors this amount of money. If it's going to achieve this, we're going to pay this, whatever. And if it doesn't achieve anything, then you've lost your, or you're not going to get a return. So New Pin achieved a return of 12.2% paid by New South Wales Treasury to bondholders as a result of the success of this program. So in a sense, you could say, well, that's fantastic. It's a win-win. The government's won because there was a cost saving. It didn't have to pay for children in institutionalisation. New Pin won because they provided a successful program. The investors won because they walked away with a 12% return on their investment. I guess this is the way it works. So investors invest in New Pin. You can see at the top. New Pin was run by Uniting Care Burnside, and the results were this restoration rate. That resulted in savings to government. Government then returns part of that savings. The government keeps some of that savings, so it's not always returning everything back to New Pin. New Pin then sort of through the New Pin Trust returns that money to investors. So in New South Wales, that's been expanded. So in recent years, it's moved into health. So the two programs that are ongoing, I think still going at the moment. One is in mental health. It's called Resolve. Another one involves palliative care, the Silver Chain Group. And the expectation in both of those is that there'll be realisable cost savings through reduced hospitalisations. Okay. So, you know, there are problems with this. It's not going to work in all parts of the health sector, but it tends to work in areas where there are very acute sort of need in terms of high levels of excess hospitalisations at the moment, and we can just sort of, if we can just find a program that reduces that excess healthcare use, returns savings to government, then the important part of this, and sorry, I haven't really sort of, is that the savings associated with this are based on economic evaluation. Okay, so these economic evaluations, how these returns are determined by government is based on a third-party economic evaluation. And myself and some colleagues have been involved in writing the guidelines for Treasury on how to conduct these economic evaluations. But it's important that these evaluations, I mean, you can't leave it to the parties themselves because obviously it's a conflict of interest. So there's got to be a third-party evaluation of these savings. So that was the social impact bond. Finally, we've got a couple of minutes, and we've already talked a bit about this health technology assessment, PBAC, use of economic evaluation for new drugs. So I won't go into too much detail, but this is a definition that WHO has for health technology assessment. Actually, we still have half an hour question and answer, don't we, Maridulu, for this? So I might infringe a few minutes into that. Health technology assessment is a multidisciplinary process that aims to determine the value of health technology and inform guidance on how these can be used in health systems around the world. And Australia was one of the first jurisdictions to embed it within government policy. So we did that in 1993. That was 10 years ahead of the UK. NICE was only established in the late or early 2000s, I think. In a sense, we're seen as a world leader in health technology assessment. So, as I mentioned earlier, it's different countries have different processes for how they do it. In Australia, we have what I call an adversarial process or a sponsor-driven process. It's based on industry making a submission. The submission is then reviewed by an evaluation team and a technical committee. So one of the evaluation teams is actually at Share, led by Richard. So they look at the submissions and pull it apart in terms of the technical capability, the technical aspects of it. So often that means, unpacking the black box of modelling that often happens. I remember when I did it in the old days, I did it quite a few years ago. We used to, not so much the evaluation, but I was on the committee. We would get a security guard, not a security guard, a courier to come with a box about this big and just wheeling into my office. And, I'd be looking at 3 or 4 submissions and all the outputs from the modelling were in the... and you had to plough through that to work out. And, part of me, the suspicious part of me was thinking, well, the part of this is obfuscation, Anyway. It was an interesting process, and this is the way it happens. There is this process of review that happens through the Pharmaceutical Benefits Advisory Committee. So feedback then goes to the PBAC, involves experts and stakeholders. PBAC makes a recommendation to Minister. The main area of contention around it is obviously cost effectiveness, but also underpinning that is price. So we can always change the cost effectiveness of a drug by lowering or upping the price. And a similar process, not exactly the same, but a similar process happens for medical services through the Medical Services Advisory Committee. So there are a number of components. It's not just economic evaluation. There's also clinical evaluation. So there's 6 sections. Clinical evaluation, then there's translating the clinical evidence to economic evaluation. Economic evaluation, that often involves modelling as well as just looking at the evidence. And then looking at the budget impact, estimated extent of use and financial implications. So it's not just whether it's value for money, it's whether it's going to cost a lot of money to the health system generally. And then looking at additional relevant information that might come into play, such as equity. Just very quickly, how an the sorts of things that we're looking out for in economic evaluation that happens through the PBAC. So obviously, the main thing is that we take a health sector perspective. It's not a whole of society perspective. It's really the impact of the new drug on the health sector in terms of costs and also outcomes in terms of health outcomes. The comparison has to be in relation to usual care. Okay, so often you see drug trials that are in comparison to placebo. So if that's the case, then we need to make adjustments to the findings in order to come up with the treatment effects that are relevant to usual care, because that's the policy question that the decision makers, it's not against a do-nothing alternative. There's always something, or usually something, and that's usual care. So we need to demonstrate cost effectiveness, but also acceptable budget impact. And there are exceptions. So there's rule of rescue. If it's a life-saving drug and there's no alternatives, or there's for rare diseases, sometimes we make exceptions to this cost effectiveness and we cut it a bit of slack. If two drugs are equivalent outcomes, but there's difference in costs, we do what's known as cost minimisation to ensure that there's matching of price. That's a fairly sort of simple case that often comes up. So what does the PBS achieve? So because government is a monopsony, a monopsony means it's the only purchaser. So it's like a monopoly, but on the other side. So monopsony is the only purchaser in the market. It has a bit of market power. So it uses that market power to, in theory at least, keep drug prices low. It bids down drug prices. It also helps industry. And people think, the PBAC is really just about screwing industry over because we're keeping prices down and trying to. But industry benefits from the PBAC because it has a target. It has security, it has a surety of a market. And if you get into the PBAC, you have, a PBS, you have a clear sort of marketplace to sell your products. And finally, it also gives Australians timely access to affordable medicines, which ultimately is the goal. I think, so summary. Okay, summary of everything. So markets involve the interaction of buyers and sellers for goods and services and are seen as an efficient way to allocate resources. Market failure sometimes occurs and often in the health sector. Economic evaluation helps governments and health funders achieve efficient allocation in lieu of markets, and some case studies I gave, social impact bonds and health technology assessment. Sorry, I've gone quite a long time, and we still have half an hour question and answer.
Sorry, we don't, Steve. We've got about 10, 15 minutes.
Oh, 10 to 15 minutes, okay.
Sorry. And if I'll just interrupt right now too and just say, when we do have morning tea, we have only got 15 minutes.
Yeah.
And so you can bring it back in if you need.
Okay.
And I'll give you
the
time frame. If you want to put it up there. Just put it up there.
No, thanks. Okay, so any questions or that you have? I know it's been a long session. Yeah.
Can I just ask, health technology assessments, how does that, what's the technology part? You gave a PBAC.
Yeah. Technology is a very broad term.
Okay.
It's a misleading term. It means new drugs, new medicines, new medical devices, even new services. And there's increasing talk about even applying it to public health. So you can even sort of try to classify new interventions in public. We're not doing that yet in Australia, but there's talk about that, at least in international context, about applying HTA to many other areas.
Hey, Steve. Really great, thank you. How do things such as models of care get assessed if they're, I'm not sure how broad technology is, but they're probably not on the drug side or the medical side? How do you weigh them up?
Look, generally speaking, they fall outside the HTA system in Australia, although to a limited extent, you could argue MSAC, the Medical Services Advisory Committee. So there are certain models of care that are funded through Medicare, like chronic disease plans. Those sorts of things are potentially, if you've got a new model of care around chronic disease management, one of the things you could potentially do is put it up for submission through MSAC, and then that would then, if it was successful, would get funded through Medicare. So some models of care can sort of get funded in Australia through that, but a lot of them, say, for instance, things that are delivered through the state health systems, that there's no formal HTA process through, at least in New South Wales, for, if you've got a coordinated care plan through New South Wales, that often happens through, through a mix of other sort of administrative considerations, perhaps cost effectiveness, but it's not at least institutionalised into their decision making.
Just following on from that, I think I'm going to designate myself as the stupid question asker for the
no stupid
group.
questions. Yeah.
But sort of following on from that and thinking about my area of research, working with nurses doing research, there's interventions that they can implement that would probably save money, but it wouldn't necessarily. We wouldn't look at it and see that it saved a life 1 year. We wouldn't get a life year out of it, or like how does economic analysis work when you're not using measures like QALYs, or is that still the same, or is that a different thing?
No, it's the same. It's the same. That would count, in an economic value. If you're preventing hospitalisations down the track,
right? Yeah.
That is something that gets captured, and we'll talk about that. But you don't have to save lives. You improve quality of life. You can improve outcomes in other ways. That will get captured in a QALY. In theory, but there may be other outcomes. I mean, it's a way. I think the question that you need to think about is if you're evaluating your program, it's not going to save lives, then you're not going to frame your economic evaluation around cost of life years saved. You would try to come up with a metric that's a bit more sympathetic to your program, and there are different metrics as we'll go through that may be more sympathetic.
Okay, thank you.
Oh, David, jeez.
Yeah, thanks, Steve. You talked about cost effectiveness thresholds.
Yeah.
And that's anyone in health technology assessments very familiar with those. But you talked about budget impact as well. I'm wondering if there's any sort of threshold or how that's evaluated.
I'm not aware of this. There's no threshold. I can give you a quick example. A few years ago, I think it's called Sovaldi. Is that called a Hep C drug that came onto, developed in the US around, I think it came before the PBAC in around 2014. It's a breakthrough drug, basically. It cures hepatitis C. And it's a drug, the previous treatments were just sort of around symptom relief, but it never cured it. But it was really expensive. And the initial submission onto the PBAC showed it was highly cost effective, but budget impact would have just been through the roof. So it got rejected the first round. Eventually, over a number of rounds and through price negotiations and what was known as a risk sharing arrangement. So that means the company takes some of the risk associated with it, and so it sort of takes a bit of the pressure. I mean, the risk to government, if you say we're going to fund this drug, because the PBS is an open-ended thing. So if all of a sudden, 10 million people sort of claim for it, there's no mechanism for PBS to prevent that. So it's taking on an open-ended risk when it sort of lists a new drug. So it had some sort of risk-sharing arrangement to provide a cap on how much the government was going to pay and how much the industry was going to take. And through those negotiations, Sovaldi eventually got listed onto the PBS. So now we have access to that drug at a potentially lower cost because of that sort of price negotiation process. But initially it was rejected, not on cost effectiveness grounds, but on budget impact. Yes.
I have a question about social impact bonds. Please correct me if my understanding is incorrect. But for example, an investor invests $1 million.
Yep.
They're going to want their return, so they get a 12% return on investment, so the government's paying them back $1.12 million. Is the government not more worse off because they could have just paid for it themselves at a cheaper cost if they paid that $1 million rather than now it's costing them $1.12 million? Or is the benefit only in the fact that they just didn't have to take that risk to begin with, so it all comes out in the wash?
That's right. I mean, you're taking sort of a rearview mirror view, because at the time the risk was borne by the investors. If that program turned out to be a dud, then those investors would have lost some of their money. So that government is just saying, well, we're not in business of taking on that sort of risk. Capital markets are good at doing that. Let's outsource that. Are
there certain interventions that kind of fall in that risk category that get push to the social impact bond sector, or is it?
Look, it's the categories of programs, particularly in healthcare, that can be eligible for social impact bond is actually quite small. It's a pretty narrow market at the moment. It's for those that where you can demonstrate in a short space of time clear cost savings in terms of reduced hospitalisations, and there aren't that many programs in healthcare that are cost savings. I mean, in my career, and I'm sure Richard and Joe and David, a lot of the programs that we do evaluations of, they cost money. They cost the health system money, but they claim to achieve benefit in terms of health impact. They're the sorts of programs that aren't that good for social impact bond. Social impact bonds need quick savings in a 3-year time frame or 5-year, whatever they're issued for, and what Treasury calls cashable cost savings. So it is a very narrow approach, and that's my criticism of this scheme. They could be a bit more generous, I think. I think they could pay out on broader sort of health and social benefits. But at the moment, they're very, very focused on cost savings.
Thank you.
Thanks.